All right. Good afternoon, good morning, and good evening, everyone, whichever time zone you are. Thank you for joining us again at the Changing the Conversation Policy Dialogue series. This month, we are focused on the theme, leveraging performance-based financing for strategic health purchasing. For those of you that joined us at the first session last month on the 19th of May, thank you so much. We hope it was an interesting time for you. And we also hope that this one will also be a very great session. My name is Oludare Bodrin. I'm Program Manager for the Strategic Purchasing Africa Resource Center. And just as we get started, as you get in on the call, I would like to walk you through just a few housekeeping rules that will ensure that you have a very smooth and productive time with us. Thank you so much again for being here. We require that you are with us. This would only take us about 90 minutes and we will be done. Just a few technology information. You can use the interpretation button if you would prefer to listen in French, or also you would prefer to listen in English when we have conversations in French. We encourage that you put your mobile phone on mute so that we can enjoy this conversation together. To ask a question or share a comment, you can use the chat box feature or the Q&A button to type in your question or raise your hands, and our team will be sure to receive your questions and channel it appropriately. For your participation, please, let's enjoy this. We believe that this is a joint participation. We love to see your engagement, your questions, your comments, like I've earlier said, and please feel free to share highlights that strike a chord to you on social media using the Changing the Conversation hashtag. Fine, well, that is all. I think that you're welcome to this policy dialogue series. Let's join the conversation and make the change. I would now turn it over to Professor Edwin Barasa. Edwin Barasa is the head of the Health Economics Research Unit, who will be framing this whole conversation for us, really highlighting some of the key lessons learned from the evidence synthesis that we had conducted relating to this theme. Edwin, over to you.
Great, thanks. My name is Edwin Barasa, as have been introduced by Dare, and I'm going to kick off this webinar by sharing some of the findings that we've had from literature review that set out to try and look at the link between performance-based financing and strategic purchasing. And the way that I'm going to do this is first you start by taking us back to asking ourselves what purchasing is, what strategic purchasing is, and then what performance-based financing is. And essentially, we know that health financing has different functions, and one of the functions is purchasing. And purchasing is quite simply that function that transfers resources of funds that have been pooled to a healthcare facility so that the healthcare facility can in turn provide services to citizens. And for purchasing to work, there are three things that have to happen, which is figuring out what services are these that we want to purchase, who do we purchase these services from, so what health facilities do we contract to provide these services, and how do we purchase, so what are the kind of provider payment mechanisms that we use and the contractual arrangements that we use. Purchasing can be passive or strategic. Passive purchasing is essentially where systems are essentially just following predetermined budgets by simply paying bills. But strategic purchasing is when the system is a bit more intentional about structuring those purchasing arrangements. So decisions about what to buy, how to buy, and who to buy from, in a way that optimizes health system goals. So equity, efficiency, quality of care, and outcomes. Next slide, Darren. Performance-based budgeting, performance-based financing is a provider payment mechanism. So it sets, as I said earlier, you have three questions to answer when we're thinking about purchasing. What are you purchasing? who are you purchasing from, and how do you purchase from? So performance-based financing sits within that third question around how do you purchase. And it's a provider payment mechanism that seeks to link financial incentives with the performance of healthcare providers. So providing specific targets for healthcare providers in terms of utilization of services, quality of services, and so on, and linking additional financial incentives to these particular targets. Performance-based financing as a mechanism has seen tremendous growth in sub-Saharan Africa over the past couple of years. So for instance, between 2006 and 2017, the number of African countries, or sub-Saharan African countries that adopted performance-based PBF pilots moved from 3 to 32. And this rapid sort of diffusion of PBF across the continent has been attributed to strong advocacy by international development agencies. And one of the rhetoric that has been used is that PBF is a potential entry point for strategic purchasing. So essentially, we set out to try and interrogate this particular rhetoric, which is to examine whether and how performance-based financing can be a pathway for a more holistic approach to strategic purchasing. We did, there are several reviews out there. So we set out to do a review of reviews, but then realized that the reviews themselves were not that detailed. And so we added a bunch of, we expanded the scope of our review to include primary papers that are qualitative in nature so that you can get the depth. And so in total, we had about 39 papers. And the range of papers that we ended up reviewing are representative of about 24 African countries. So essentially saying that the experiences from the review are quite representative across the continent. Next slide, Dario. Next slide. Our review was guided by the theory of, Spark's theory of change, or conceptual framework for strategic purchasing and how it links to health system goals. So this framework essentially assumes that for strategic purchasing to occur, then you need, strategic purchasing awareness and evidence. So you need the system and system actors to be aware about strategic purchasing and what works and what doesn't. And then you need strategic purchasing capacity. So capacities around governance and institutional arrangements, capacities around underlying health system functions, capacities around coherence across the system, transparency of decision-making, and so on. And all of this then enable what we call strategic purchasing functions. And here we focused specifically on 4 functions: so benefit specification, contract arrangements, provider payments, and performance monitoring. And the idea is that when you have this in place, then purchasing can then be able to, can be used to leverage on resource allocation, incentives, and accountability. And these can in turn impact on health system goals. Next slide. So what did we find? We found that the policy dialogues that are used to introduce PBF can raise awareness around aspects of strategic purchasing. So the dialogues that are in place at the beginning can raise awareness around aspects of performance budgeting, PBF. But the challenge is that these dialogues are often quite narrowly defined, so restricted to PBF and its mechanics and so on, rather than broader strategic purchasing functions. Sometimes they can be misleading in the sense that they've assumed that PBF and strategic purchasing are synonyms, so equating strategic purchasing and PBF. And the dialogues are also typically externally driven by international actors and sometimes exclude the local actors, in the sense that while the local actors are part of the dialogue, their thoughts and views and contributions are not really taken into account. And so they're not allowed to factor into the design. So one of the lessons we learned out of this is that increasing awareness around strategic purchasing requires adequate and ongoing engagement with technical and political actors, particularly those at the Ministry of Health. But this advocacy needs to be more widespread, including the relevant range of stakeholders, including frontline people and people at the communities. Next slide. Can PBF strengthen governance capacity in contexts where financing arrangements are weak? So for instance, in places where you have, that are emerging from conflict, PBF, there's evidence that PBF can improve governance by defining clear accountability frameworks, separating some key health financing functions by introducing these functions and agencies and clarifying actor roles. However, when this same mode is sort of transplanted to a setting where you have well-established structures, then it creates parallel institutions that increase fragmentation. And sometimes some of these arrangements are not aligned with health systems' capacity to implement them. And so the systems become overburdened and sometimes carry out these functions in an inadequate way because their capacity is not matched to what they're being expected. Next slide. So some of the lessons we learned out of this is that there's need for clear and streamlined institutional arrangements that identify each of the purchasing functions that need to be carried out, with institutional players carrying out each functions and how. So clarity of roles is quite important. And there's also need to sort of calibrate the complexity of these arrangements with the underlying capacity and evolving that capacity, complexity as the capacity of the system improves. Next slide. Can PBF improve benefit specifications? We found that PBF can indeed improve benefit specifications since PBF explicitly translates health priorities into payments for access to specific services. PBF sometimes also has a requirement to publicize price lists, and this can improve citizen awareness for their entitlements. And these are all positive aspects that can promote strategic purchasing. However, PBF often focuses on a narrow set of services and sometimes been found not to be flexible to be able to address local variations in health needs, and monitoring mechanisms are not very strong. Then non-incentivized services are sometimes deprioritized or crowded out. Next slide. So some of the lessons we've learned is that streamlined benefit packages rather than multiple benefit packages through different schemes are more easily understood by beneficiaries and providers. We also learned that adding detail within benefit specification, the purchasers can provide clearer information to providers about what is expected in terms of service delivery, demands, and service quality. Next slide. Can PBF improve contracting arrangements? Again, in settings where you have weak or no contractual arrangements within the system, PBF can improve contractual arrangements by introducing contracts with clear rules and rules and guidelines for providers. However, where strong contractual arrangements exist, PBF does not have a meaningful impact on contractual arrangements and instead adds to the fragmentation, adds another layer of contracting, which adds to the burden that healthcare providers have to deal with. And further, when PBF contracting is done outside the public sector or MOH, the schemes tend to have minimal effect on improving contracting. Next slide. So it is quite important that contracts are streamlined and as well as clear and precise about responsibilities for each side. It's also important that contracts are used as a tool to communicate priorities. The implementation and enforcement should facilitate providing feedback on performance rather than punitive action. Next slide. Does PBF improve payment arrangements? We found that PBF indeed has a potential to facilitate that transition from input-based to output-based financing. However, the way in which PBF schemes are implemented is that these output-based arrangements are essentially just add-ons to the traditional input-based budget. So they have very minimal effect on having real reforms in provider payment. PBF often fails to align with existing financial arrangements. So oftentimes they're implemented in settings where you have, for instance, out-of-pocket payments as a major barrier to access. So when on the one hand, you have out-of-pocket as a main financing mechanism, creating a barrier to access, and then on the other hand, you're trying to incentivize increased access. There's a contradiction in terms there. Payment delays often affect incentives, with lengthy verification processes being seen as a common reason for these delays. And we find that there are cases of lack of transparency in bonus distribution, which affects or compromises the sort of underlying assumptions around how PBF works, because it affects the motivation of healthcare workers when they think that the bonus system is unfair. Next slide. So payment incentives need to align with service delivery objectives and should be streamlined and harmonized across different payment systems, especially if multiple funding sources are paying providers differently. It's also quite important that payment processes are administratively streamlined to avoid payment delays and burdensome claims processes. Next slide. Can PBF improve performance monitoring? PBF can indeed improve performance monitoring by specifying targets, reporting outcomes, and conducting verification. PBF can also strengthen information systems by linking payment incentives to accurately reported information. However, we found that the potential for PBF to strengthen monitoring is often limited by poor integration of PBF programs with the rest of the system. Parallel monitoring systems can also lead to competing priorities that are burdensome to frontline workers. They're also costly and burdensome, and they tend to be externally driven. And when they're externally driven, they compromise financial sustainability because they're quite costly, they compromise national ownership and internal capacity development. Next slide. So the lessons we get out of this is that reporting requirements and data quality should be made explicit in contracts with providers and the monitoring systems of purchasing agencies. Monitoring information should also be shared with providers, along with supportive feedback to enable dialogue between purchasers and providers. It's also important that the intensity of monitoring and verification should be balanced with what it can help accomplish in terms of improved accountability and provider performance. Enabling environment, we found that it is quite important that there is an enabling environment to allow performance-based financing to work, and in turn to enable strategic purchasing. And some of the things that we found around general socioeconomic and political conditions, so strong socioeconomic environment and political environment tends to enhance the performance of PBF and strategic purchasing more generally. It is also quite important that there's a strong underlying health system function to enable PBF schemes to achieve their objective. You know, someone from, I think, Zambia once said that performance-based financing is meant to be the cherry on the cake. So if you do not have the cake, then why are we talking about the cherry? So you need a very strong underlying health system function. It is quite important that you have health provider autonomy. For performance-based financing to work, incentives have to reach the providers. And if the providers do not have the agency or the decision space or the autonomy to act on these decisions or on these incentives, then PBF collapses. Health provider management and leadership practices are quite important. We found that inclusive and distributed leadership practices rather than top-down hierarchical styles promote the achievement of PBF objectives. And of course, it is important that PBF objectives align with the prevailing cultural norms and practices, or at least seek to address them. Next slide. So the lessons we got out of this is the strategic purchasing policies and approaches should align with current capacity of the health system, including its infrastructure, staff availability, skills, geographical conditions. Strategic purchasing systems should also be flexible and adaptable to changes in the context. We also, another important lesson is that providers need sufficient autonomy and management capacity, and that strategic purchasing is more effective when health providers have strong management capacity and the right leadership practices. Thank you. So this slide essentially just summarizes everything, which is that PBF can indeed raise awareness for strategic purchasing, can improve institutional and governance arrangements, and strengthen strategic purchasing functions. However, the extent to which PBF has been able to do this has been limited in scope and practice because PBF has been introduced primarily as a separate financing mechanism. So parallel to existing systems, not very well integrated, mostly as pilot projects, and so it has failed to have a more meaningful impact on the larger system. Thank you. Over to you, Dario.
Thank you so much, Professor Edwin. Thank you so much. We know a lot has gone into this. Quickly, there's just one question on the chat box that I'd like you to respond to. And this person is asking, how is this useful in a public-private partnership situation? How, I'm guessing this means that, how is PBF leveraged to implement system-wide strategic purchasing under a public-private partnership situation? Yeah.
Thanks, Dario. I mean, so those are two questions in one. I mean, first is that, as you mentioned, so PBF is a provider payment mechanism. So it depends on who the purchaser is, and it depends on how you answer the question of who do you purchase from. So if you purchase from the private sector, then you can contract the private sector and specify a payment arrangements that includes incentives. But so that's that's a rather straightforward technocratic answer. But the more important thing is that for PBF to have an impact, then it needs to be integrated and be part of the entire system rather than run as a parallel small pilot project. So whether you engage the private sector or not, if it's a small private project, a pilot project, it's not going to have meaningful impact. So I think that's a bigger question, how to scale and integrate to the entire system.
Yeah, thank you so very much. Please keep your questions coming in. We're collating them, and we would raise them at different points in the conversation. Thank you so much, Edwin. This is really helpful. Just to inform that the entire work that has been done that you have seen in this presentation actually is documented in a policy brief that we have on our website. I'm sure the link is going on the chat space right now. It contains all of the lessons and all of the findings from this work. So please feel free to go check it out and read for more details on what Edwin has just presented. Great. We are going into a session of panel conversations now, and I will like to turn this over to Isidore. Dr. Isidore is the co-founder of R4D International in Cameroon, and he will be taking us through a panel discussion with some of our policymakers from Uganda, Cameroon, and Nigeria. Isidore, over to you.
Thank you so much there. Thank you, Prof. Edwin. I think, yes, we really appreciate, what the knowledge you share. I think that is very, very important, for us, especially because now we try to, hold a small panel discussion. And for our panel discussion, yes, I have the privilege of moderating, the panel, this panel, but the credit goes to my three panelists, whom I'm honored now to introduce. Our first panelist is Dr. Ngozi Anlaigbe from Nigeria. Dr. Ngozi is a public health physician and consummate administrator with over 15 years of experience in management. And currently, she is responsible for the National Health Sector COVID-19 Pandemic Response Action Plan for Nigeria. She is the director responsible for coordinating national health policy and plan. Dr. Ngozi has led several senior positions within the system, including coordinating the development of the National Health Act, health emergency, resource mobilization, and driving the health Millennium Development Goal, as well as the SDGs effort. Following Dr. Ngozi, let me also shed light on Dr. Tamga Denis, a Cameroon-based medical doctor specialized in public health. Dr. Tamga previously served the Ministry of Health as the National Performance-Based Financing Unit as technical advisor. Currently, she's supporting the World Bank portfolio in Mali, providing technical assistance to the PBF project. And over the years, Dr. Tamga has developed extensive expertise in the PBF policy cycle from local, sub-national, and national levels in several African countries. And our last but not the least panelist is a gentleman from Uganda, Dr. Tabusibwa Eri. Dr. Tabusibwa is currently the team lead of the National RBF unit at Ministry of Health, Uganda, Kampala. For the last 3 years, he has extensive experience for the last years. Now he has extensive experience of more than 20 years working in health sector with the last 10 years in health system strengthening. So please join me in welcoming our two panelists. If you are ready, let's just keep in mind that our session will discuss about leveraging, the PBF schemes for more system-wide strategic health purchasing, focusing on opportunities, challenges, and practical lessons, different countries can learn from our three representatives. We will start with the Uganda case, since it was the last to be presented. So Dr. Tabusingwa, please, in 5 minutes. We know that Uganda has a long history implementing PBF program. You have recently started a new RBF program in Uganda called Uganda Reproductive, Maternal, and Child Health Services Improvement Project in 2017, with the aim to improve the provision of maternal, newborn, and child health services with funding from the World Bank and the Global Financing Facility. How does the new program improve, on the previous RBF program, and how you are mainstreaming, the RBF program in the Ministry of Health without creating a parallel structures? Please, Dr. Tabusingwa, you have 5 minutes. Thank you.
Yes, thank you very much. I'll do my best to be within the time allotted. But first and foremost, I would like to just greet everyone. I know some it's good morning, good afternoon from whichever time zone you are in. Specifically to the questions one, the current national results-based financing program was designed from studying a quick analysis, a review of the previous RBF pilots that have been implemented. Some were demand side, some were supply side, and the effort was really to understand what works, to understand how the different structures can be engaged, to understand how to incorporate results-based financing within the mainstream, the health sector as such. And there was a critical analysis of the gaps, the challenges, the strengths of the previous pilots, with a view of trying to learn and incorporate the different lessons learned into the current practice. And it's still a work in progress. We've been formally implementing RBF for the past, effectively the purchasing started exactly 2.5 years ago. And so it was really we didn't start it from scratch, and the current model, which, because previously the closest pilot that informed the national program was running in about 80 facilities, and we've currently rolled it out to about it's over 1,300 facilities that are primary healthcare facilities, including regional and general hospitals. So it's really from the critical analysis of the different the pilots. In addition, there was so from what was studied, it was seen that it is important to have, if a PBF framework, a PBF intervention is to really be effective, you need to utilize the key structures in the sector. And in Uganda, the Ministry of Health, you find there's a health sector budget working group which is responsible for financing issues. So it oversees the financing interventions in the sector, and it is rooted within the planning department, which oversees health financing. And as such, it has the opportunity, there's an opportunity to regulate and to guide health financing with the PBF approach. In addition, from the review, there was a results-based financing framework for the health sector that was developed to guide what are the different undertakings and considerations, and to give a framework within which results-based financing works. In regards to the next part of the question, in regards to what we have seen, no, I think that is it.
Yeah, oh, no, thank you very much, Dr. Tafsingwa. Yeah, very interesting story indeed. And I think this is really in line with, the evidence that we just heard from Dr. Professor Edwin, sorry, that yes, it's very important, to calibrate the institutional arrangement in the capacity, of the country. Since we are not starting from zero, it is really important, to take into account, what we have, what we have in place as advantage, really to calibrate on what we want to introduce as a new mechanism. Now let's, travel in Nigeria, where the design of the state national health insurance schemes commenced in the middle of the implementation of the PBF program. Dr. Ngozi, how did the PBF program influence the design and implementation of the state social health insurance scheme in Nigeria? Was PBF supportive of the implementation of these new schemes, or did it present additional challenges? So I don't know if Dr. Ngozi is there. Please, we want to hear your thought on this. You have 5 minutes, please.
Okay, thank you very much. I want to thank everyone for being on this call. Thank you for also having me on this call. The SSHIs had been, in the works, prior to the commencement of the PBF. We had a number of all of that going on, but we had the PBF, and what we did was to provide
Dr. Ngozi, are you okay? Sorry.
Yes, I'm fine. I'm fine. I'm having a bit
Thank you.
My connection here.
Yeah, thank you.
What the PDF did was to provide learning that was used, to further strengthen and inform improvement and to upscale the state social health insurance schemes. But it was also put on hold because of some stakeholder disagreements. This is by way of background. So, but in 2012, the Nigerian government then launched the State Health Investment Project with 2 different payment mechanisms for service delivery. They were performance-based financing to provide financial incentives to health workers based on the quantity and the quality of service they provided. This was decentralized at the facility level, where we did what we call the decentralized facility financing scheme, and where health facilities received a certain payment regardless of the quantity of services they delivered. Okay, this intervention were also implemented in 3 states in Nigeria. We had one in Adamawa, one in Ondo, and one in Nasarawa. These 3 states are in 3 different zones. Nigeria has 3 zones. We have the Northeast, Northwest, North Central, and then the Southeast, Southwest, and South-South. So the 3 states were in the different zones. Through the PBF, therefore, was a good tool for broadening the scope of the state social health insurance scheme and its focus. It provided for us institutional coordination, but some of the incentive strategies could not work well with the state social health insurance scheme structure, since it could not be sustained. So PBF provides room for engaging and provides health stakeholders, opportunity to build on existing performance strategies and improve on that. But it was not necessarily the government system where the state health insurance was basically based. So what we're saying here in effect is that the state health insurance is usually completely government, but PBF could be government, it could function sometimes independent of government, but it provided us with all the information that we needed to strengthen, the state social health insurance scheme. Thank you. Over.
Thank you very much, Dr. Gozi. I think also very, very interesting story. Important to see that the PBF program was able to provide a comfortable room of maneuver where it was possible to build the new schemes and even try to leverage on the experience of the PBF experience. Let's now go in Cameroun. Dr. Tamga, je sais qu'au Cameroun, un sujet dont nous avons très souvent entendu parler, et assez fréquemment d'ailleurs, et qui limite considérablement la capacité des prestataires à répondre aux incitations financières, est la rigidité des directives de gestion des finances publiques. Ce qu'on appelle généralement en anglais le PF1, le Public Finance Management. Et la particularité au Cameroun, c'est effectivement, et je pense dans tous les pays, c'est que effectivement tous les prestataires doivent se conformer à cette directive de la gestion des finances publiques. Alors, Dr. Tamga, est-ce que vous pouvez partager avec nous l'expérience du Cameroun sur la manière dont le pays a élargi l'autonomie des prestataires pour répondre aux incitations financières fournies par le projet de financement basé sur la performance, et quels sont peut-être des indicateurs de manière concrète que vous avez vu s'améliorer grâce à ce changement dans la gestion des finances publiques. Donc, retenez s'il vous plaît que vous avez aussi 5 minutes pour nous partager votre expérience. Merci.
Ok, merci Isidore pour la parole. Bonsoir à tout le monde. Déjà, il faut dire que pour le cas du Cameroun, le financement basé sur la performance a démarré en 2011 avec un pilote qui couvrait 10% de la population. Et actuellement, on est à 100% de la population qui est couverte. Le projet est cofinancé par les fonds de l'État et les fonds de la Banque mondiale. Effectivement, la mise en œuvre du PBF n'a pas toujours été facile au Cameroun, il faut le dire, surtout avec cette rigidité des finances publiques. C'est-à-dire que les critères d'allocation des ressources étaient très rigides au niveau des formations sanitaires publiques avant le financement basé sur les performances, quoi. Donc, avant le financement basé sur les performances, ce qui était fait déjà, c'est pour l'allocation des cartons aux formations sanitaires, ça se faisait sous forme de lignes budgétaires. Lorsque l'État commence donc à cofinancer donc l'approche, il a donc fallu revoir un peu ces mécanismes et désormais les fonds sont alloués aux structures maintenant sous forme d'un budget en forfait, on peut dire. Donc on paye les résultats et le PBF a été inscrit, le financement basé sur les performances a été inscrit dans la loi des finances et les fonds PBF qui dépendent des finances publiques sont payés directement par le trésor public. Donc, voilà un peu un mécanisme qui a été mis en place pour alléger un peu l'autonomie financière au niveau des structures sanitaires. Mais en dehors de cela, il faut dire aussi qu'il y a eu des décrets ministériels qui ont été signés, 2 décrets ministériels. Le premier décret déjà, c'était pour autoriser cette autonomie financière parce que le ministère des Finances a été assez résistant à payer les structures sanitaires dans des comptes privés. Parce qu'avant, on les payait dans des comptes au trésor public, mais avec le PBF, on leur paye dans les comptes, dans les banques commerciales. Donc, il y a eu donc eu cette décision ministérielle qui demandait au ministère des Finances de payer désormais ces subsides à travers les banques commerciales. Ceci donc a permis aux structures sanitaires de pouvoir mobiliser leurs ressources en temps. Il faut dire qu'à titre de rappel que lorsque l'argent était payé, les crédits étaient octroyés à travers le trésor public, il était très difficile pour les formations sanitaires de mobiliser cet argent. C'est-à-dire, en début d'année, une structure sanitaire peut savoir qu'elle a peut-être 3 millions de crédits, mais à la fin d'année, c'est difficilement qu'elle réussit à décaisser cet argent. Il faut aller négocier avec des procédures compliquées, parfois même au trésor, c'est des pourcentages qu'il faut donner pour avoir quelque chose en retour. Donc, il y a eu cette décision ministérielle qui a aidé à libérer les choses. Première chose. Deuxième point, autant pour moi. Le troisième point également, c'est toujours la deuxième décision ministérielle. Cette fois-ci, qui allouait plutôt les structures sanitaires à acheter les médicaments auprès des grossistes agréés, surtout en mettant l'accent, la priorité sur les médicaments essentiels génériques. Parce que avant le PBF, il faut dire que l'achat des médicaments, on devrait acheter les médicaments uniquement au niveau de la centrale nationale d'achat. Mais avec les expériences et les taux de disponibilité qui étaient suffisamment faibles, il y a eu donc une décision ministérielle pour leur permettre d'acheter ces médicaments. Donc, avec tous ces réaménagements qui ont été faits, on a véritablement constaté des améliorations au niveau de beaucoup d'indicateurs. Notamment, il y a eu une augmentation de l'utilisation des services de santé et surtout les services préventifs tels que la vaccination, la planification familiale et la qualité des soins. Donc, ça, c'est ce que l'évaluation d'impact avait montré. Parce qu'avant le PBF, il faut dire aussi qu'avant le PBF, les fonds de l'État n'étaient que donnés aux structures publiques. Le privé était carrément exclu de la démarche. Or, le privé au Cameroun couvre 44% de la demande. Ça veut dire que le public est à 56%, donc ils étaient d'office exclus. Maintenant, quand on intègre ces privés, on voit que l'utilisation des services s'améliore, la qualité des soins s'est améliorée. Il y a eu plusieurs études dans ce sens. Ceci grâce à la capacité d'innovation des structures sanitaires et à l'autonomie dans la gestion des différentes ressources qu'ils ont. Et qui dit augmentation d'utilisation des services dit aussi augmentation des recettes des structures sanitaires et aussi l'amélioration de la gestion financière, surtout pour ce qui est même des aspects de gestion des crédits. Parce qu'avant, les gestionnaires des formations sanitaires vous disaient qu'on a envoyé le crédit, mais nous n'avons pas pu décaisser. Or, actuellement, parce qu'ils avaient des problèmes de décaissement au niveau du trésor, c'était devenu une routine de vous dire qu'on a donné 1 million, mais je n'ai que eu 500 000. Mais est-ce quelle était la véracité? On ne sait pas trop. Donc ça, c'est des anecdotes qui étaient racontées par un peu les gestionnaires des structures sanitaires. Mais avec le PBF, comme on paye dans leur compte, les fonds sont traçables et la gestion financière s'est améliorée à travers l'outil indice.
Merci,
comme autre indicateur.
Merci. Docteur Tabga?
Oh. Oui,
Allô?
oui, docteur Isidore.
OK,
Oui.
non, je pense qu'on va revenir vers vous après. Très intéressant de voir effectivement cette histoire un peu du FDP au Cameroun et très intéressant de voir effectivement tous les aménagements qui ont été effectués dans le cadre de la gestion des finances publiques. So let's now go back to Dr. Ngozi. Try to understand more the experience, the Nigeria experience. So Dr. Ngozi, the PBF program has officially ended in Nigeria. At least that is what we know. Are the gains from this program being sustained? How and what are the main challenges to the sustainability of the PBF enabler reforms? And also what were some of the main lessons learned from this experience? Please, can you just give us your thought in, let's say, 3 minutes, please? Dr. Ngozi? Probably Dr. Ngozi is facing some challenges. Are you with us, Dr. Ngozi? Okay, if I think Dr. Ngozi is facing some challenges, so maybe let's go to Dr. Tabusingwa. Okay, Dr. Tabusingwa, are you online? Can you hear me?
Yes, I am. I can hear you.
Okay, thank you very much. So what tips or advice will you give other countries on how they can incorporate, the improvement in purchasing functions resulting from the PBF to improve system-wide purchasing functions, beyond the PBF schemes level?
Okay, thank you. First and foremost, I think one, it's important that the country owns the intervention. When I say own, it's important that the different levels of government, from both the political arm and the technical arm, are on the same page in as far as an intervention that is looking to improve performance is concerned, regardless of the sector. The other is it's important that governance issues are very clearly dealt with at all levels. And when I look specifically at the health sector, governance at the central level, at district level, even at the levels of implementation. So as part of the design, the different roles and responsibilities should be very clear. It should be very clear that the different key stakeholders, even, for instance, the fund holding, the verification, and everyone's role should be very well defined. And it's important to have adequate capacity at all levels and understanding of the strategic direction and the strategic objectives. This means that from the very beginning, dissemination or sensitization of all stakeholders in as far as what the intervention is about and what everyone's role and responsibility is should be handled as part of entry at all levels. It's also important, so PBF, if I can allude from some of the challenges we've faced, it's important. We had a misfortune. Okay, we're unfortunate that we had a very rapid rollout that outstripped our capacity to meet the demand of what we needed to do. We are looking to address that, but it's important that the necessary investments, human or otherwise, are available to deliver the intervention, right from central level. If you're having a coordinating unit, making sure things, processes are digitalized. We've had an experience where we rolled out in piecemeal. We scaled up in phases, but we reached a point when you spend lots of time on manual processes, and yet you need to be focusing, probably spending a bit of more time on the analysis for the evidence at work. So the different investments need to be in place. Because results-based financing promotes falsification of data, because there's a financial benefit, it's important that there's a good balance of penalties that are going to reinforce the positive behaviors. But it also means that you also have to, you cannot underscore the need for verification, and which is as objective as possible. In our case, we are having a decentralized responsibility to the districts to verify the facilities. Some of it is objective because we can look at what they've reported in HMIS, but it's important that the verification function is clearly well thought through, with an opportunity to counter verify as and when is necessary to minimize losses or wastage of resources. Well, for now, I think, yes, I think that for now, that should do. We can always have additional input at a later point in time. Thank you.
Thank you very much, Dr. Tabuzigwa. Very, very interesting story indeed. I think it is really important, and from what I heard, from your story, that it is really important to think about, the governance of the purchasing functions in terms of, system-wide approach. Think also about the governance of the purchasing agency, because that is also very important. But very, very important to also think about the information system, because we cannot talk about strategic purchasing without a robust information system mechanism. And it is really important to think about the information system in terms of digitalization. We cannot expect to scale up interventions in all the country without thinking about reducing the burden or the load of the work. If we still continue using our traditional paper-based information system, rapidly we end up with a lot of challenges. So there is a clear necessity to think about all of this. And I think this is some key lessons that we learned from the previous program. Yeah, very, very happy to hear that. And I think it's really in line with what we heard from Professor Edwin. Now, Dr. Tamga, très intéressant de voir effectivement les progrès effectués au Cameroun dans le cadre du financement basé sur la performance. Belle histoire de la question sur la gestion des finances publiques. Peut-être notre préoccupation maintenant, c'est de savoir, parce que nous savons aussi que le pays est en train de mettre en place un système national d'assurance sociale. Est-ce que dans ce cadre-là, est-ce qu'il est prévu d'exploiter les leçons tirées de la mise en œuvre du programme de financement basé sur la performance pour, par exemple, établir les fonctions d'achat de ce nouveau régime national d'assurance maladie du Cameroun? C'est quelque chose que je pense que les participants souhaiteraient davantage comprendre un peu de l'expérience. Si vous pouvez partager ça avec nous. Tamga?
Oui, Isidore, merci beaucoup. Effectivement, avec la mise en œuvre du financement basé sur les performances, il y a beaucoup de leçons que nous avons tirées pour les travaux de préparation de la couverture santé universelle. Donc, l'une des premières leçons apprises, c'est qu'il est important de prendre en compte l'équité dans la fixation des coûts des services de santé, surtout en particulier dans les zones rurales qui sont mal desservies et où la population est pauvre et de faible densité. Donc, on ne peut pas fixer un même coût pour tout le monde. Donc, on a défini le paquet des soins et on est en train de travailler par rapport à quel coût il faut appliquer. Première chose. La deuxième chose que nous avons vraiment appris, c'est que pour mettre en place cette couverture, la deuxième chose, c'est qu'il est important de faciliter la mobilisation des fonds et d'assurer le paiement des prestataires dans les délais. Si les structures de santé ne sont pas payées à temps, c'est clair que ça va être difficile de réussir la CSU, quoi. Donc ça, c'est la deuxième leçon apprise. Et la troisième chose aussi que nous avions appris, c'est qu'il est important de communiquer, mettre en place une communication stratégique à tous les niveaux sur le paquet des soins, communiquer sur le paquet des soins de manière à ce que chacun puisse savoir qu'est-ce qui est attendu, qu'est-ce qui est payé dans le cadre de la CSU. Parce que si les prestataires aussi ne connaissent pas les soins qu'ils doivent offrir et qu'ils font des factures qui ne correspondent pas, il y aura des cas de rejet. La même chose pour les cas des bénéficiaires. Ils doivent savoir qu'est-ce qu'ils ont droit pour ne pas attendre des prises en charge qu'ils ne pourront pas avoir à la fin. Ça, c'est un point. L'autre point aussi que nous avions appris, c'est qu'il est important que le ministère de la Santé aussi aligne le paquet des soins des différentes interventions pour plus d'efficience. Donc, on se rend compte qu'il y a plusieurs services qui sont couverts, qui sont surcouverts, pendant que d'autres services ne sont même pas couverts. Donc, il va falloir aussi travailler pour aligner le paquet des soins. L'autre leçon apprise, c'est que nous ne pouvons pas travailler sans le secteur privé. Il est important aussi, dans le cas de la CSU, de contractualiser le secteur privé. Mais pour le moment, on a prévu de commencer d'abord avec les structures privées confessionnelles. Ensuite, il serait aussi important de renforcer la prestation des services de santé. Il y a beaucoup de formations sanitaires, mais en termes de capacité à offrir le paquet de soins, il va falloir renforcer ces structures sanitaires parce qu'on se rend compte que si l'utilisation augmente et qu'il n'y a pas la qualité, les assurés ne reviendront sans doute pas dans les structures sanitaires. Et le dernier point que je pourrais citer, c'est le groupe technique qui s'en charge, qui travaille sur la CSU, pense aussi en train de réfléchir sur les modalités de rémunération des prestataires. Comment on va les payer? On a mis en place la CSU, on va mettre en place la CSU, mais comment on assure les autres sources de motivation? C'est-à-dire que la motivation intrinsèque pour que les prestataires s'appliquent à offrir les soins à la population. Donc, voilà un peu les quelques leçons apprises qu'on compte capitaliser dans le cadre de la mise en œuvre de la CSU au Cameroun. J'allais oublier le dernier point.
Oui,
il y a un dernier point
en
avec
quelques secondes.
c'est mettre en place. Oui, merci. De mettre en place aussi un système de vérification robuste et renforcer le système d'information sanitaire. Merci à vous.
Parfait. Merci beaucoup, Dr Tamga. Je pense que c'est très intéressant de voir effectivement toutes ces leçons que vous venez de partager, qui, beaucoup de points se réfèrent aussi à ce qu'on a entendu du côté de l'Ouganda, notamment la question de la gouvernance et de la question de l'information sanitaire. Et à cela, vous avez clairement aussi précisé la nécessité d'aligner le mécanisme de paiement des prestataires, mais aussi le paquet de soins. Et sans oublier que la finalité de tout le système, c'est effectivement la notion d'équité dans le système. Je pense que c'est quelque chose qui doit être au cœur de notre intervention. Et nous sommes vraiment ravis que vous ayez suffisamment bien élaboré sur cette expérience. So, can we try now to join Dr. Gozi? I hope now everything is okay on the side of Nigeria. Dr. Gozi, can you hear me now, please?
Yes, I can.
Thank you very much. Excellent. So the PPF program has officially ended in Nigeria. Are the gains from this program being sustained? That is the first thing that we would like you to, let's say, share your experience on. And if yes, how? And also, what are the main challenges to the sustainability of the PPF enabler reforms? And what were the sum of the lessons learned from this experience? I know it seems like a lot of questions, but in clear, can you just please share the main lessons, from what you observe in the PPF program in Nigeria in terms of, sustainability of the program, leveraging on the program for the new schemes and so on. Thank you very much.
Thank you very much. I'm happy to be back, and the network is much better now. The PPF program that just ended in Nigeria, we learned quite a bit. We learned that the incentives provided to the health workers contributed to the reduction in the charges for some services that the patient had to pay for initially when accessing services at these centers. The health worker did not have to ask for extra charges from patients, and they still delivered quality services to in the quantities that were required. I think that was a critical learning for us, because it also showed that when people are incentivized and they have a stake in the system, they go the extra mile. I think it was just a simple economics of scale. And we also learned that the PPF incentivized facilities had autonomy, which was critical for the optimum functioning of the facilities. So because they had autonomy for daily decision making and for service delivery, it helped them a lot. They also had powers over their resources. They could take decisions. They had powers over the resources. And it helped to ensure that services were maintained at all times and in good quality and in increasing quantity. There were the roles and responsibilities. Some of the things that we often notice in our facilities is that there were not always clear delineation of roles and responsibilities of each of the actors. But under the PBF, because of the necessity for accountability, the roles and responsibilities of all the actors were clearly defined, and people did adhere to their roles and responsibilities. And it was easy to hold people accountable and to understand where any weakness was coming from, if there were weaknesses. Also, contracting arrangements, especially where the private sector was engaged in service provision, were very clear, and we leverage in the design for engaging health management organizations and private providers in the state social health insurance scheme. These were important things that we learned. Of course, we also found out that in order to fully operate this in the public sector, we needed to again revisit the funding mechanism or fund release patterns or the rigidity of funding within the public sector, because a number of the things that we were able to do under this project are things that you ordinarily would not be able to do routinely, under the public healthcare financing mechanism and the budget processes of government. So that was one of the things we learned, were how can we make these things work for us on a sustainable long-term basis. The PBF, so on a sustainable long-term basis. And if we're asking, was the PBF supportive of implementation of state social health insurance schemes, and did it present additional challenges? Well, I just stated one of them. It's one of the challenges was the financing structure, the budgeting structure and financing mechanism within the public sector. Some of the things that the way funds were released directly to facilities are not usually, the case in the public sector. So that was a challenge. The additional challenge is that government cannot sustain the gains of the PBF because of the huge costs associated with this implementation. Otherwise, the performance of the PBF helped provide momentary strengthening of the health system at the time. I think the challenge for us would be how to walk through the benefits and situate it with the current realities. The PBF we operated was based on a loan, and that resource came from the World Bank, and it provided more resources than ordinarily any facility in Nigeria would get. It came on time and it was released timely. So I guess if we had all that resources, it would be easy for us to work with. So what we're looking at is, having learned some of these things, what can we apply? What is possible, within the public health system? How can we use that to improve the system? How can we ensure that the gains of the PBF can be mainstreamed into the system? So certainly the gains are being sustained in some way, especially using the experiences and the skills acquired. We're trying to see how we can use all of that to move forward with other health system interventions. Part of what we've learned is the value of building the capacity of staff. Part of what we've learned is the value of incentive. Part of what we've learned is the value of some degree of autonomy and a recognition that comes with it, and the need for accountability. So we're looking at how we can mainstream some of those lessons even within the conditions of the public health care financing and the budgeting processes that obtains in the public sector. So we also must appreciate some of the not so favorable aspects of the PBF. The huge cost, the money is not there. Before the COVID, the money was not there. With the COVID, the money has disappeared. And those are issues that we are looking at as government. So for me, my takeaway from this meeting will be how I can also learn from the experiences of other countries and some of the studies that have been done, by this very distinguished group, to see how we can, take the goodness or the strengths or the benefits of PBF and mainstream it into what we have. We may not get 100% of what we need to have, but we'll be making incremental progress in the right direction. Thank you very much. Over.
Thank you very much, Dr. Gozi. Very, very interesting, indeed, experience from SAIF of Nigeria. I think it is really important, to keep in mind the several challenges that is in line also with the PBF program. Some days, might be better than other one. In Cameroon, we had very, very, positive experience on the PFM. It seems like in Nigeria, we still have some, some challenges in line with the PFM. But also all the experience shared here, shed light on the fact that it's important, for countries to think about domestic resource mobilization, because we cannot continue, reflecting the sustainability of the PBF program on the donors' funding. I think that is not sustainable. We really need to think about domestic resource mobilization, think about injecting more funding to the health system. But I think above all, it is important to see that yes, the PBF as a scheme, serve as an entry point for in many countries to think about comprehensive approach, to think about introducing reflection on strategic purchasing to several components. For instance, provider payment, autonomy, and so on and so on. So thanks to all of you, but I would like to ask you, please, the panelists, if you can stay for additional few minutes, because we have received a lot of questions from the participants. So I would like to direct some questions to you. Please, in 1 or 2 minutes maximum, please, you will need to answer those questions, and only one question per panelist. Let's start with Dr. Denise. The question from one participant: how did you incentivize quality in your PBF program? What sort of quality metrics were used, and how did you measure success? Please, Denise, in 1 to 2 minutes, please. Hello? Can someone hear me?
Allô? Allô?
Yes,
vous m'entendez?
Dr. Tamga. Oui, allez-y, s'il vous plaît.
Merci, sorry. J'étais en mute. Merci déjà pour la question. Il faut dire que la qualité des soins est à mesurer à travers une checklist qui comprend plusieurs types d'indicateurs. Il y a les indicateurs structurels, en termes, par exemple, est-ce qu'il y a un pèse au bébé à l'hôpital? Est-ce qu'il y a une table d'accouchement? Ça, c'est l'un des éléments qu'on regarde. Mais en dehors de ça aussi, nous avons les indicateurs de processus qui regardent un peu comment la qualité des soins est faite. Donc, par exemple, est-ce que les protocoles de prise en charge du paludisme, est-ce qu'ils sont bien respectés? On regarde un peu qu'est-ce qui est fait. Donc, ça, c'est un peu les éléments qu'on utilisait pour évaluer la qualité des soins. Et le dernier point de la qualité aussi, c'est la qualité relationnelle. Parce qu'on faisait également des scores, des enquêtes de satisfaction des patients. Et on a vu qu'avec le PBF, cet aspect a été amélioré dans les formations sanitaires. Il y a les formations sanitaires tiennent compte des besoins de la population. Ils ont amélioré les temps d'attente, ils ont amélioré l'accueil, par exemple. Donc, c'est un ensemble de plusieurs indicateurs. Merci, à vous.
Merci beaucoup, Dr. Tamga. Excellente réponse. Let's now, go to Uganda. Question for him. The supply side incentive mechanisms of PBF is more or less clear. Can you share with us the experience whereby demand side payments to individuals, households, or communities conditional on engaging in pre-agreed healthy behaviors or utilization of health services have proven to work in our continent, Africa? Please, Eric, 1-2 minutes.
Well, thank you. From the experience and from documentation from previous interventions, especially on demand side, it's clear that, yes, it improves utilization of those who are being targeted. Now, the question that probably has been difficult to say is it sustainable? Is it scalable? Are you going to recommend some of the versions we have seen? And that's a question that if you're talking mainstreaming, if you're talking the government taking it up, that is a different matter altogether. But the evidence has shown from the pilot projects that have been reviewed that especially the voucher schemes, specifically speaking to the voucher schemes, that those who are being targeted, the poorest of the poor, if such a thing exists, with a bias in maternal child health services, that when the implementing agency is keen on identifying these based on a poverty index, they actually were able to reach. But even then, there are also biases, there are negative biases. There are some people once in a while who would access vouchers and yet they probably have the capacity. But yes, the general answer is yes. The interventions work. Sustainability and mainstreaming is now the question that probably cannot be easily answered because of the resource implications of those schemes. Thank you.
Thank you very much, Eric. Thank you. And finally, Dr. Ngozi, what are some examples, of criteria for incentives for provider that you use in Nigeria? Yeah, Dr. Ngozi.
Okay, thank you very much. Yeah, sorry, I was talking without my microphone on.
Okay.
Thank you very much. Well, we had quality was defined and all of that was done. But I want to ask one of my colleagues, Dr. Nneka, to also, add her voice to what Nigeria did to ensure quality.
Okay, thank you. Yes, thank you very much, colleagues. So in responding to the question, how did we define success and how was quality rewarded and all of that? So ab initio, all of the strategies for doing this were laid down. So we had people who engaged patients at the health facility after they had assessed care. So that would mean that they were there to complete the patient exit forms. And these responses were analyzed, for decision making. And of course, quality was defined also. For example, for a woman to come for ANC and then complete all of the periods for coming for ANC, they had number of attendance that a woman has to complete. So the woman completes it and the health worker is incentivized. and then the woman goes through labor and delivers a live baby, you know. So that's also was also defined. So health worker behavior and relationship with patient. So all of these contributed to defining quality and success. So depending on how many live babies a healthcare worker has delivered and all of that. So those were the things that were incentivized, and they contributed to quality care delivered. Thank you, and over.
Thank you very much, Dr. Nneka. Yeah, we are now at the end of our panel discussion. I'm very, very grateful, you know, to all participants, and I would like to also thank the 3+1 panelists. And now also, let me turn the floor to Cheryl, you know, for the key messages. Thank you very much.
All right, thank you, Dr. Isidore. Just like you have said, and thank you everyone for following us this far. We are almost done. Just like Isidore has introduced, I'll introduce Cheryl Cashin, Managing Director, Results for Development, to kind of pull all of what we have heard together into what are the key takeaways we should go with as we wrap up this session. Please give us just a few minutes. We will be done. Cheryl, over to you.
Thank you so much, Dare. The panelists made this job very easy. So thank you so much for this rich discussion. And thank you, Edwin, for setting the stage so well, and Isidore for moderating a great session, and of course, to our panelists. I want to go back to what Dare said at the opening of this session. And we're calling this series Changing the Conversation. So changing the conversation about strategic health purchasing. And in this particular webinar today, we wanted to change the conversation from does PBF work to can PBF be leveraged to advance strategic health purchasing more holistically in health systems of sub-Saharan Africa. As Edwin reminded us, this is a very pervasive policy solution that has been adopted over the past decade. And a lot has been done to study this from the perspective of does it work, but we really want to look forward now, a forward-looking conversation about how to leverage PBF more system-wide. And I think the messages that Edwin shared from the evidence synthesis were a bit sobering at first glance, that there wasn't a lot of indication that PBF has had system-wide impacts on improving strategic health purchasing more holistically. And that is largely because it has been introduced in a narrow way. It has not really been integrated into mainstream health financing systems, has remained really at the pilot phase. And also, as we heard from Edwin and even from a number of panelists today, there might have been a mismatch between the sophistication of these solutions within PBF and the capacity of the health systems that they were brought into. All of that said, we still have a lot of lessons that we can learn from this vast experience over many countries over more than a decade. And I think these lessons are really valuable for countries, as the countries we heard today in the panel, that have or had PBF systems, and how to take that forward and take those lessons forward, take the capacity forward, and have a wider impact on strategic purchasing in those countries. But I think the lessons are also valuable for others who may not have ever adopted PBF, but are still committed to strengthening strategic health purchasing in their systems. So we have, I believe, 13 lessons outlined in the evidence synthesis and the policy brief that I hope you'll take a look at. There's a link in the chat. But I want to just pull out 4 that I've heard today that are just so critical, and we have this really rich country experience to back them up. The first lesson is whether you are implementing PBF or introducing broader strategic health purchasing arrangements, you need to involve a wide range of stakeholders. Purchasing touches on so many stakeholders. We're talking about how funds flow through the system, who gets paid what and how. This involves a lot of stakeholders, and they need to be at the table as you're thinking about how to take this forward. And then engaging them in determining the roles and responsibilities, who will do what, making that very clear. And then that comes to the next lesson that I thought Dr. Eric said so nicely. You need to calibrate the complexity with the capacity. So as you introduce PBF or any kind of strategic health purchasing arrangements, you can start simple and go forward, or you can start more sophisticated. It really depends on what the capacity of the system is at that moment to meet your system where it is and build from there. And that's something that I think we heard a number of really important examples of where that makes a lot of difference. We heard the example of verification a number of times from our panelists, that maybe the verification systems in PBF were more sophisticated than the capacity of the system could bear. And that was a bit of a drain in terms of costs and sustainability, but also a drag on the incentives themselves, that if the verification systems were too complex, that then led to payment delays, which then, of course, will weaken the incentives in the payment. But I think this is a very important lesson for strategic purchasing more generally, that if you are paying based on claims or other kinds of reporting systems, to have that be as administratively simple as possible and streamlined so that there aren't delays in payment to providers, so that the incentives work as planned. And I think this also links to the point made about the information systems. Again, trying to align the complexity with the capacity. And we heard from a number of our presenters how important data analysis is for PBF implementation and improvement, but also, of course, for strategic purchasing more generally. Having information available that you can analyze helps you, first of all, to calibrate your incentives, to know if you are having the impacts on provider performance that you aim to have, and then to have that intelligence in real time to adapt. And so I think I heard some possible lessons here about maybe starting simpler and smaller so that you can automate and then growing from there, rather than starting a very massive paper-based information system and getting bogged down in that paper-based system and never getting to the point where you can actually analyze and give rapid feedback and generate that real-time intelligence in your system to keep improving. The third lesson that I thought was quite important had to do with provider autonomy. And this was an important lesson that came out of Cameroon's experience. In a lot of the systems that are relying on input-based budgets with more rigid resource allocation and less flexibility for providers to make management decisions internally, financial incentives don't have much of an effect. If providers can't respond, then those incentives either don't have an effect or in fact can do harm if you change the incentives and providers can't respond. And so in the case of Cameroon, having this pilot of PBF and having that kind of safe space to test out provider autonomy gave a lot of confidence to go forward and understand how important this was, and to be able to convince the Ministry of Finance to introduce more flexibility and provider autonomy in the system. I think that was a lesson that came out of Nigeria's experience as well. And that ability to have a safe space to test out new approaches might also apply to engaging the private sector. I think we heard that as well. So that was a great lesson that I thought we can all take about the importance of provider autonomy, but maybe testing it out on a smaller scale to gain that confidence and experience. And that brings me to the final lesson that I think really is the most important one, and that is any new approaches that are tested and tried in the countries in health financing and strategic purchasing, that these are all an opportunity to learn. And so all of the learning that happened over the past decade plus implementing PBF, I think is really now being brought to bear in all of the countries to apply strategic health purchasing more holistically. And I think I'll stop there and turn it back to Dari for the closing. But thank you all for this wonderful, rich discussion. I think has advanced the PBF conversation that has been going on for a long time. I think there's been a lot of wonderful steps forward. Thank you so much.
Yeah, Thank you so much, Cheryl, and thank you everyone for joining us on this call. We are coming to the end of this meeting. Please feel free to check the link that has been shared. Please drop thoughts about what you think about this webinar. We have a survey link that has been shared. Please also don't forget to check the link to the policy brief on the work that has been done on strategic performance-based financing for strategic health purchasing, and other policy briefs that we have, and other curated resources. For your questions, we will bring them together and we will respond to them in subsequent publications. So please look out in your emails and look out on our website, and you will get more information about this webinar. We will be coming back very soon with another session discussing another interesting topic. And until then, we will keep you posted. Thank you so much, and enjoy your day. Enjoy the rest of your day. Goodbye.